Phoebe is a 62-year-old female with a diagnosis of hypertension, diagnosed at age 55. She has pure hypercholesterolemia. She is in the overweight category for the BMI, her BMI being 29. She has CKD3A with an EGFR of 48 and a creatinine of 1.3. Former history of tobacco use. She quit 10 years ago after a 30-pack year history. She also has a family history of premature CAD with a father who had a heart attack at age 45, who's coming to your clinic with uncontrolled hypertension. She was recently admitted for an episode of flash pulmonary edema. Today in your office, her blood pressure is 165/95. And this is fairly consistent with prior readings. She is currently on valsartan, hydrochlorothiazide, the combo of 320 and 25 respectively, nifedipine XL 90 milligrams, which she's been on for the past 2 weeks. For many years, she was actually controlled on HCTZ 25 milligrams and nifedipine XL 60 milligrams. So this has been a little bit of a change for her. She does not have adrenal adenoma or hyperplasia, according to our expertly read CT. She does not have sleep apnea. She does not have a history of alcohol use. She's not taking NSAIDs. We are not filling her full of steroids. She does have a recent echocardiogram, because who in this world does not, with an EF of approximately 55 to 60% with impaired relaxation of the left ventricle. So what we're trying to paint a picture here, I think, is actually perhaps a patient with renovascular hypertension. So I'm wondering if you sort of talk us through what that even means, I think, to start, and then we'll sort of talk about what the workup looks like and where to go from here.
All right, so the renovascular hypertension in this patient, the big clue is the flash pulmonary edema. And if she was on that was before she was started on the valsartan, I think, and then her blood pressure is controlled after that. Or actually, it's not controlled. So that's... Renovascular hypertension is something that can provoke flash pulmonary edema, and that would be an indication to pursue maybe a workup or intervention, especially if it occurs when they're on an ARB already. So I've seen a few cases of that where they're on losartan or maybe a lower dose ineffective ARB, and they still have severe episodes of hypertension that can just come on episodically. That can happen with renovascular hypertension and cause pulmonary edema, especially if they have a little LV dysfunction. So renovascular hypertension is not just a blockage in the kidney artery. It usually has to be pretty severe enough to cause an ischemic insult to the kidney that provokes renin release, and that provokes these episodes of hypertension. I see a lot of cases that have a little bit of a stenosis on either angiogram or renal duplex ultrasound, and not everything that you see there is causing renovascular hypertension. I've sent plenty of people to an intervention, and they don't improve after having that stenosis relieved. So resistant hypertension is just super common, and you have to be really selective in those patients that you really work up for this or send to an intervention, especially.
Can you explain to me, I feel like I'm missing something obvious here, but the sort of paroxysms of hypertension, or sort of these patients sort of crashing the flash pulmonary edema, I guess, mechanistically it makes sense if you would start someone on like an ACE or an ARB, and then their blood pressure would go up like that or their creatinine would go up, that I can kind of track. But why are they having sort of these episodes? Like, what's the periodicity and what's the mechanism behind that?
It's not super common, and I'm not sure that I can explain why it happens episodically like that, but it does. That's not an unusual story. And part of it may just be that their ARB is not an adequate dose, or it's not long acting enough, or they periodically forget to take it. I try to use the highest dose of a longer acting ARB as I can. I tend to use olmesartan in those patients that I'm trying to get the longest activity of an ARB. So that's typically what I'm using nowadays, although, like everybody else, we evolve in practice. So that's, I've seen plenty of people, and those people that do present with flash pulmonary edema that is due to the renovascular hypertension, they do tend to respond pretty well to the intervention. So an angioplasty or stent. A stent would have to be done if they've got atherosclerotic disease.
Yeah, in this patient, we gave you all the risk factors for atherosclerotic disease plus the age. I know when you read about this topic, they always mention like fibromuscular dysplasia. So like, what does that patient look like? How would that patient look different from this patient?
Somebody with fibromuscular dysplasia, you can present later in life with fibromuscular dysplasia. So don't discount it in a 55, 65-year-old woman, because they can present later in life. I've seen that. But typically, classically, it is a younger woman. The fibromuscular dysplasia is more of kind of a developmental disease. So it's like a web-like interference with the blood flow. So the way that the vascular people have described it to me is like a spiraling or like a web-like blockage of blood flow. And to really know for sure, you have to go do an angiogram, put a wire across, and measure the pressure, because sometimes it can look pretty bad on angiogram, but there's actually no pressure drop across the lesion. So to know for certain that you're doing something that's going to benefit the patient, you need to do a pressure gradient measurement and then do the angioplasty. The good thing about FMD is that these patients are typically younger, 95% female. So it's pretty unusual for a male to have this, but can happen. But it usually just needs angioplasty and not a stent, unless there's like a complication, which can happen when you try to angioplasty. You can have a dissection, or spontaneous dissection can occur with FMD. And then the other thing is they have disease elsewhere in their body. So they have carotid, vertebral disease. You have to listen everywhere. So listen over their brachial arteries, femoral, listen over any artery you can think of. You might hear bruit. I've heard it over the brachial artery, different arteries across the body. And I typically don't deal with the carotid and vertebral. We've got a vascular team that also kind of helps do that evaluation, but they can also have coronary artery dissections as well. So that's, not a totally benign disease, but it's usually the patients that I'm seeing are focused on just the kidney artery. So I try to intervene when we can.